Hello, everybody. I'm Sylvie Garcia-Houchins. I'm the Director of Infection Prevention and Control here at the Joint Commission. I thank you for joining me today. Today we're going to be talking about ways to prevent transmission of coronavirus. Our intended audience today is really anybody who's dealing in a healthcare setting, and that may be anywhere from a behavioral health setting to an ambulatory care setting, a nursing home, really any setting. The importance of this update is that we have taken all the information that we know of as of today to update information that was previously presented. We've learned a lot in the last 4 to 6 weeks, and so we want to make sure you're as up to date as possible. Before we get started, I want to acknowledge the sacrifices that many healthcare providers have had to make over the last 2.5 months. It really has been a difficult journey. And I also want to recognize all of our essential workers who are there helping those frontline staff to be able to provide excellent and safe care. This is our standard disclaimer for the Joint Commission. Our slides are current as of May 15th, and as you go through other webinars that are available, please make sure you take a look at the date that they were last updated. So these slides are meant to only be cue points, and we hope that you will take the time and listen to the presentation as we try to expand on what is being presented in those slides. Please remember these slides may not be used further, shared or distributed without my permission or the permission of the Joint Commission. We do welcome you putting it on your website or sharing it with your employees, but we ask that you not use it in further presentations. As we start, I want to make sure that you understand that this is background information, right? This is the information that we believe organizations need to use to make decisions about how best to protect their staff and their patients. This information should be laying the foundation for how you are operating moving forward. One of the things I want to emphasize is that in the creation of this presentation, we really tried to focus on the safety of your staff with the belief that staff safety is essential to the ability of any healthcare organization to provide safe care to their patients. As this picture from the CDC shows, when someone coughs, sneezes, or even talks, they create droplets or respiratory secretions. People who are in close proximity get infected with COVID-19 when the virus in the droplets land in their mucous membranes, that is your eyes, your mouth, or your nose, and they become infected. Other people touch surfaces which are contaminated by the droplets, and they inoculate themselves. They touch their eyes, their mouth, or their nose themselves. Aerosol generating procedures may put staff at risk because a larger amount of different sized droplets may be generated and remain suspended in the air for an increased period of time. That increases the likelihood of exposure. Think of the old Peanuts character, Linus, walking around, right, with a cloud around him. That's how you should be thinking about aerosol generating procedures. So one of the things that we have learned about coronavirus is really the idea of asymptomatic and pre-symptomatic spread. Initial information about COVID-19 identified symptoms similar to influenza, fever, cough, and shortness of breath, and initial reports indicated that 90% of cases had fever and or cough. This initial information led healthcare providers to focus on identifying patients with these symptoms as the primary control measure. It also focused our testing on people who had these symptoms. However, when investigating an outbreak at a long-term care facility, back in March, when we first started seeing coronavirus in the U.S., the CDC tested 76 residents who were exposed to a healthcare provider with COVID-19. They found that 23 residents were positive for COVID-19. Of those 23 residents, 8 had typical coronavirus symptoms, fever, cough, or shortness of breath. But 2 had only atypical symptoms. They had malaise, not feeling well, nausea, diarrhea. And 10 residents had no symptoms at all at the time of testing. Over the week following testing, 10 of the 13 went on to develop symptoms. It took them about 3 days. That was the average time after testing that they then developed symptoms, consistent with COVID-19. But 3 never developed symptoms. There have now been multiple reports of people who were COVID-19 test positive but have not had symptoms. So it's an important concept to remember. Anyone could have asymptomatic COVID-19 infection. Anyone. Any person who has been out of their home, any person who has had someone come into their home. If there is any opportunity for interaction with another person, there is a possibility of asymptomatic coronavirus. We can't tell by symptoms. We have to use what we know to stop transmission. There's been a tremendous amount of emphasis on personal protective equipment and the types needed as well as the lack of it. But PPE is just one level of controls needed to control the spread of coronavirus. And in general, PPE is the least effective means of preventing transmission. As you can see from this diagram, in CDC's hierarchy of controls, eliminating the hazard is the most effective measure. Organizations can eliminate the risk of exposure to someone who has asymptomatic or pre-symptomatic COVID-19 infection by limiting visitors. Right? How often does someone come into your healthcare facility and bring multiple family members or a number of care providers? Right? Now is the time to think about limiting the number of visitors to those who are really necessary for the care of that one patient. Right? It may be one person or it may be no one. It depends on the situation with that patient. But it's very important for you to let your patients and visitors know ahead of time. The risk of staph exposure can also be decreased by substituting a higher risk procedure with a lower risk procedure. For example, something that we've been doing very effectively is telehealth instead of in-person visits. By implementing engineering controls like physical devices, plexi shields at entry into your facility where someone is being greeted is also a great way to prevent transmission. And then there's administrative controls. That's how we normally would do our work. We have to start thinking about how do we do our work differently so that we are preventing exposures. And then finally, there at the bottom of the hierarchy of controls is the least effective method, which is PPE. And we need to differentiate personal protective equipment that is being used as source control versus personal protective equipment that is being used as protection for our staff. We need to use everything that we know to prevent transmission of COVID-19. As you can see from this picture, putting a barrier like a face covering or mask over the nose and mouth can be used to decrease droplet dispersal. This is known as source control. But source control by itself is not enough because perfection is not possible. Some people will wear a mask covering incorrectly or only intermittently or not tightly enough, thinking that they are not at risk around coworkers or family members is sometimes an issue, so people take off their masks. Following the hierarchy of controls, organizations need to implement multiple interventions to stop all possible routes of transmission. Social, or more accurately, physical distancing, can help eliminate the hazard. Sometimes this is impossible when providing patient care, but organizations need to look outside of direct patient care and think of all the opportunities to implement social distancing. How do you handle celebrations amongst your staff, group meals, and staff meetings during this pandemic? Everyone needs to be committed to appropriate use of personal protective equipment every time in any situation when your organization has identified the need. And of course, hand hygiene and diligent cleaning and disinfection remain the cornerstone of infection prevention and control. Because of its importance as a control measure, one of the assumptions that we are making during this presentation is that your organization is implementing source control, which we consider synonymous with the term universal masking. That means that at any time someone enters your organization, be it patient, visitor, or staff member, they are wearing some type of face covering upon arrival to your facility. Now, we know there are situations, such as in behavioral health facilities, where it may be necessary to modify source control. It may be that a patient may not be able to wear a mask, in which case we need to protect others around that patient by using personal protective equipment and increasing that observance of social distancing by other patients and making sure that we aren't allowing transmission to occur. In a healthcare facility, we are familiar with CDC's recommendation for respiratory etiquette, and the poster on the left is a means of stopping the spread of respiratory illness. These recommendations are based on the presence of respiratory symptoms. It's what we're used to seeing when we walk into most healthcare facilities. However, we now know that COVID-19 can be transmitted by people who do not have noticeable symptoms. Therefore, the best way to stop COVID-19 transmission is two-pronged. Stop dispersal of all respiratory droplets. That's what you do when you do source control. And prevent exposure to respiratory droplets. That's what you do when you wear personal protective equipment. This means that our conventional posters, like the one on the left, need to be relooked at and revised to something like the poster on the right, which emphasizes that anyone outside of their home or entering a healthcare facility should be wearing at least a cloth mask, some type of face covering, as a means to prevent transmission in the community, and more importantly, in your organization. If you follow the link on the statement that I gave on the previous slide, or at the bottom of this slide, you will notice that you can print this poster as it has been made available to anybody going to our website. We've also provided it in color, so if you prefer color, you can go to our website to this link and print that color sign. You will notice that we are using the term face covering versus face mask. A face covering is worn to prevent droplet dispersal. A medical or surgical mask is worn to prevent droplet dispersal and to protect the employee who is wearing it or the person who's wearing it. It's personal protective equipment. Remember, surgical masks are Class II devices that cover the user's nose and mouth and provide a physical barrier to fluids and particulate materials and are tested for flammability and biocompatibility. So there are different types of masks. What we are finding is that organizations need to be careful as this public health emergency has resulted in the sale of face masks that resemble a surgical or procedural mask but do not meet that standard. It's very important that you look at the box and you read carefully. As part of the hazard assessment required by OSHA, organizations must identify when a face covering is sufficient and when a face mask must be worn as personal protective equipment by staff. It's important to evaluate this for all job duties in your facility. As part of their infection control risk assessment, organizations should also identify face covering requirements for patients. For those organizations who will require a switch from cloth coverings to medical or surgical face masks, the organization should develop a process for storing the cloth masks so that they're available when the person leaves the facility. Many organizations utilize brown bags and label them with the person's name. They have the individual perform hand hygiene, take off the mask by touching the ear loops or the ties, and then carefully place the mask into the bag. And then they repeat hand hygiene. When they're ready to put on their mask again, their cloth covering, their face covering, then they do the reverse. Hand hygiene, put on the mask, hand hygiene again. It's important that we not assume that staff members know how to safely wear a mask. We've provided this poster to help you remind your staff on the do's and don'ts of wearing face masks and cloth coverings. At any time that you can reinforce adherence to safe practices, you move your organization toward safety. So we encourage organizations to use reminders, including posters, tips of the day, even thanking staff for taking their time when removing personal protective equipment safely. We need to encourage best practices. That includes when they leave your facility, so that when they come back, they are safe or as safe as possible to your patients. Face masks should be prioritized as personal protective equipment for staff, and organizations are encouraged to provide information to patients on how to make their own masks prior to arrival. Instructions for sewn or non-sewn, such as these, are available on the CDC website, and many organizations have been able to ask the community organizations for donations of cloth masks that can then be supplied to visitors and patients when they enter your facility. There has also been campaigns to centralize the use or the distribution of masks that may not normally be available to some organizations. Please avail yourself of these resources. If you go to your internet site, you can do the 100 million mask campaign, and there is a link for healthcare organizations to ask for masks that have been donated to be sent to them. We need to think about safety when it's not possible to wear a face covering or a face mask. Examples include times like meals and changing masks. Organizations can have a good plan, but these are some of the details that could allow transmission to happen. So we really need to think through, what do staff do when they come to work? How do they move through their day? And when is it possible that transmission could occur because of a change in personal protective equipment or something else that they are doing? Social distancing really means identifying all the opportunities that exist to ensure physical distancing. That includes distancing staff from patients as well as staff from staff. Initially, we heard a lot of information from organizations that were doing a great job doing social distancing of patients from staff and vice versa, but they weren't thinking about staff to staff, and we're still doing face-to-face shift report. And because they didn't know about asymptomatic spread, we're putting staff members in a situation where there could be transmission between the two. Anytime there are two people together, such as in a waiting room, when providing care, eating or taking a break, or socializing even, there is a risk of transmission if source control and social distancing are not maintained. Now, this doesn't mean we can't interact. We just need to remember to maintain that 6-foot distance between everyone when possible. And as we will emphasize repeatedly through this presentation, social distancing applies to staff, visitors, and patients. Risk of transmission if source control and social distancing are not maintained is really critical. Now, there's also been a lot of information out there about personal protective equipment. And our routine patient care has changed because of this pandemic. When we only had to worry about symptomatic patients with COVID-19 infection, the ways to prevent exposure seemed very clear. But now we have to think about asymptomatic patients and how do we prevent exposure. Testing all patients has been proposed, but at this point, that is not a reliable intervention to eliminate risk. We have to assume that a COVID-19 person could enter your facility. You will note that I said a COVID-19 infected person because it could be a visitor or a staff member, not just the patient. In addition to a face mask at all times, so you will notice it says face covering at all times, we need to think about following standard precautions. Organizations need to address specific situations where exposures could occur based on the planned patient activities. When does a cloth mask need to be changed to a personal protective equipment face mask? OSHA requires that organizations evaluate the risk, determine the appropriate PPE to reduce or eliminate the risk, provide the necessary PPE, train their employees on how and when to use the PPE, and finally enforce compliance. In this situation, it is up to leaders to develop and implement a plan that keeps their staff safe while conserving resources as appropriate. One of the best practices that you can do is to involve your staff in this process. They know what they do during their day. They know what the challenges are. One of the challenges that we have been hearing a lot about is patients who cannot wear a face covering because of their underlying medical conditions or some other reason. The expectation with source control is that even patients, while they are in their rooms, are wearing face masks if anybody enters their room. And that can be a real challenge for some organizations. So thinking about when is it important for your staff to be wearing a mask that is personal protective equipment is very important. Now, it's been a real challenge keeping the amount of supplies for some organizations. And depending on where you are in the country, it's been more difficult than in other places in the country to get particular supplies or products necessary to supply your staff for this pandemic. CDC has provided strategies and optimization criteria. Important for organizations to realize that although many of us are in this contingency capacity and we're trying to save our PPE for our healthcare providers, if you are getting to the point where you are going to be reaching crisis intervention, you are not going to have enough for your staff to be protected, it is critical that you contact your local public health authority and seek assistance from them. In this case, they may be your only good link to personal protective equipment. All the states are working diligently to make sure that they are sourcing and able to help you get that personal protective equipment. Sometimes it may be that your local health authority has none, but they know of another organization who could share their personal protective equipment with you during your crisis, a few days while you're waiting for a delivery, right? Or have some other way of some other suggestion for personal protective equipment that maybe your organization has not thought about. But please do not get to crisis capacity before contacting your local health department. So now I'm going to go through the optimization strategies that were presented by CDC and the FDA as far as how do you optimize use. So for face masks, CDC has come up with a lot of information, and I think the big switch has been since the start of this pandemic is thinking about how your staff is using their face masks. So initially, CDC in their recommendations said reuse or practice extended use of face masks. The difference between reuse and extended use is that when you reuse a face mask, you put on the face mask and then you take off the face mask and you store it. Then when you need it again, you put on the face mask and then take it off after you've used it and you store it. And you repeatedly do that. Extended use means that you put it on at the beginning of your work shift and you don't take it off until you're either not going to use it anymore, or this is the difference between extended use and limited reuse, or you take it off for your break, you have your break, you have your lunch, and then you put that one back on. Organizations have had to implement this differently. So extended use means I put on the mask, I don't take it off again until it's time to go home or it's time to take my break, and at that point it's discarded. That is the preferred method. If you cannot do that because of limited supply and you are in crisis situation where you could run out and not have sufficient PPE, then limited reuse would be the alternative. Meaning you put it on at the beginning of your shift, as I said earlier, and you use it until you absolutely have to take it off. Now there is some caveat to that, which is if it becomes wet or soiled or damaged in some way, you need to have enough supply left for your employees to be able to switch out that mask. The next strategy is about eye and face protection. Important to note that eye and face protection, the important part is we're trying to protect the eyes. So no matter which you choose, it is imperative that you have solid side shields. And you can see these two examples provide side protection and some top protection also. Most organizations that we've talked to have shifted to some type of reusable device. Even if it was a disposable, you can do extended use, meaning you put it on, you leave them on. You can usually wipe those down between uses until they become clouded and you can't see. This really is the optimal strategy at this point, which is to have your staff put on a face covering, such as these, and then just leave them on. As far as gowns, over the last 20 years, we've made a switch. We made a switch from cloth gowns to disposable gowns. But as one of the contingency strategies, CDC really talks about the use of cloth gowns as a contingency strategy. Right? It is important for your staff to know the difference in how they would take off a cloth gown versus a disposable gown. The other thing that we need to be careful of is when staff take off their gown, there is a great risk of contamination. Studies have shown up to 50%, maybe even higher, of staff who take off their gown could contaminate themselves. So very important that they take off that gown carefully. We have provided video links in our Joint Commission coronavirus website. One of those links is how to take off a disposable gown and gloves, and it is step-by-step, including the rationale for each step. 2 other videos are also included, taking off face masks, taking off eye protection, and use of cloth gowns versus disposable gowns. CDC recommends in a crisis capacity that you do extended use. That's the easiest and safest for the staff member. That means they put on their gown and they leave their gown on, just the same way you would a face mask. The danger here is that if you have a patient and you are providing a lot of care, a lot of hands-on care, and you contaminated the front of your gown, and you go to another patient, you could cross-contaminate. So we need you to think about that as far as the safety of other patients and how you might do that. CDC has provided a burn rate calculator. Right? The rate of supply use depends on multiple factors. A key suggestion is to include staff in evaluating and determining the right PPE at the right time and location so they understand the rationale and are invested in conservation strategies. Through the reviews of reports to the Office of Quality and Patient Safety here at the Joint Commission, We would like to emphasize that transparency, inclusion, and clear communication are key in ensuring that staff feel safe as possible in the PPE that you've provided and that they are compliant with use and conservation strategies. As I started this presentation of this slide, you'll see that we have provided you with a great link. Please use it to try to estimate how much PPE you will need. According to the CDC, aerosol generating procedures are those procedures that are likely to induce coughing and result in a release in a high number of respiratory droplets, which may lead to the spread of respiratory infections. Would your staff be able to speak to what aerosol generating procedures are done at your facility and what PPE should be required, or what room the patient should be in ideally when an aerosol generating procedure is done? The list that we provided here is not all inclusive, but it is a list to think about that should jog that conversation. One of the key things to remember is that eliminating the hazard is an important strategy. That means restricting the staff in the room to those who are needed to perform the procedure in order to maintain the patient's safety. Another aerosol generating procedure that I want to make sure that you're aware of is nebulizer treatments. Nebulizer treatments were recently shown in a CDC report to have been linked to infection for staff with COVID-19. Therefore, it's important to determine when and how these types of procedures should be done. These are a procedure that are often done in multiple venues. So you want to take a look at what's happening at your facilities. Respirators are a key safety measure when performing aerosol generating procedures. And many professional organizations are now recommending use of N95 respirators for care of any patient, regardless of their COVID-19 testing when the procedure is being done. However, many healthcare settings have never used respirators, and respirators are in short supply, and you may struggle to obtain or maintain a supply. We want you to know that there are different kinds of respirators, some of which are disposable and others that may be reusable. Depending on your choice, you may need to modify your work practices to ensure that you maintain a sterile environment, for example, if you're using these in an operating room setting or somewhere else where sterile procedures are being done. The CDC has a great resource to explain the differences between these types of respirators and provide help in which you can use to guide your choice for what is the best for your organization. There's also been a lot of discussion about reuse and decontamination of masks and respirators. We have put on our Joint Commission Corona website this link under the section of personal protective equipment. It addresses the issues of reuse and decontamination of those respirators. It's a great resource and really summarizes the information that was available and provides those important links so that you can make your decision for your organization. Regardless of which respirator your organization chooses, you need to make sure that your organization is compliant with OSHA's requirement for a respiratory protection program. For example, if you choose to use an N95 respirator, OSHA requires implementation of a respiratory protection program. That respiratory protection program may require medical evaluation of staff who are using the respirator, fit testing for those staff, and that every time the respirator is used, your employee does a fit check. Training and competency of staff for PPE is essential. Once organizations identify when and where the PPE should be used, they need to ensure that staff are knowledgeable about what PPE is appropriate and competent on how to don and doff. As I said earlier, numerous studies have shown that it is in the doffing of the PPE that many staff end up exposing themselves and possibly others. In addition to this, if staff do not feel comfortable in putting on or taking off their personal protective equipment, they may feel increased anxiety or fear about providing direct patient care. There are many sources available. We encourage you to review the videos that are available on the Joint Commission website, as they have been vetted for accuracy and safe removal. Many of the videos that are available in the public domain have steps that are not safe. So you need to make sure that whatever your source is, that it is credible and it will provide protection to your staff. We've had a lot of questions here at the Joint Commission about cleaning and disinfection of surfaces in healthcare facilities. And the wonderful news is that facilities can usually use the same routine products that they have always used. However, there have been some supplies issues reported. So what we have done is we have provided you with the link on this slide that will take you to the EPA website, and you can look up any product name that you can get to see if it is effective against COVID-19. As I said earlier, meticulous cleaning is an important role in infection control, and determining the best schedule and how to get it done are incredibly important in your planning. The other important thing to think about is room turnover after aerosol generating procedures. In the days before coronavirus, it was not unusual, for example, for an ENT clinic who was doing rhinolaryngoscopes on each patient that they were seeing to turn over the room immediately after each patient. We now need to think of that as an aerosol generating procedure. How do we limit who's going in, and what's the time before someone else can safely enter the room? Room turnover between cases may be very different today than it was in the past because of aerosols created during an aerosol generating procedure. CDC recommends that the room be allowed to sit for a period of time to allow for removal of airborne particles. For example, if it's a procedure room where you are performing aerosol generating procedures and there are 12 air exchanges, that's the column on the left, your organization may need to wait 23 to 35 minutes. It's very important that you talk to your infection preventionists and seek guidance from them on what the time would be. So disinfection, we've had a lot of questions also about disinfection of soft surfaces. It's important that we clean the surface before, remove any visible contamination, be it dirt or some other type of organic matter like vomit or diarrhea. What has been found is that laundering is a good way to remove the coronavirus from a surface. Follow manufacturer's instructions and use the warmest water setting for the item and then allow it to dry completely. There are also some products that have been EPA approved with emerging viral pathogen claims, and you can find them on this website. As we near the end of this presentation, we need to remind organizations that your plan is only as good as your weakest link. As you look through this slide, think about what is happening in your organization. The weakest link is going to be different for every organization. It may be that you have plenty of ventilators, but you don't have enough tubing, or you don't have the staff to clean the ventilators in between use. You really need to think about what is the weakest link at your facility and how are you going to remedy that link. So in summary, I want to take us back to CDC's hierarchy of controls. CDC's hierarchy provides a framework to ensure that opportunities are not missed. It's also important to have clear communication with frontline staff, as some of the best practices that we have heard of come from frontline staff trying to solve real problems. Managers need to feel comfortable providing feedback on those suggestions and bringing them forward to senior leaders and others for possible implementation. No suggestion should go unheard. We are all being overwhelmed by a great deal of information being brought forward by media and other sources. Many times these include information that has not been fully vetted and include theoretical information that is really not actionable in real life. We want to emphasize the importance of using credible resources and information. And so we would point you to our website where we have vetted this information and ensure that it is credible and reliable. Remember that even after there is reliable testing and effective vaccine for COVID-19, we still need to think about what's next. There will always be the next possibility for an emerging infectious disease like COVID-19. So as we are learning what works today, we need to think about how we implement them moving forward. We have provided you with this link to our standards interpretation site. We ask you to use this link to submit your questions about this presentation or other questions that you have about COVID-19. If you mention this presentation, they will be routed to me or someone else who is knowledgeable about infection prevention and control. So I thank you for joining us today, and again, acknowledge your contribution to keeping your staff and your patients safe. Have a great day.